the meningococcus is here and Dr. Upul Dissanayake is here. So Dr. Upul Dissanayake is no stranger to us. He's a pillar in the College of Physicians. He's a consultant physician, the National Hospital of Sri Lanka. And he will talk to us about an important contagion, meningococcus, which is an important public health as well as a curative health problem. Over to you, Dr. Dissanayake.
Shall we start with the case history? There's this 25-year-old who came to the ward on day 4 fever with severe body aches, severe headache, the petechial rash in the trunks and limbs with a white cell count of 14,000 and platelet count of 28,000. And he's there with shock. What is your diagnosis? Ladies and gentlemen, just because I'm presenting meningococcus here today, it doesn't change the epidemiology of the illnesses in Sri Lanka. It is dengue hemorrhagic fever. And the next patient is a 32-year-old healthy male, a mango seller on the street from Boomandal. He comes with fever, chills, rhigos, myalgias for 2 days. And on examination, there was this widespread purpuric rash with conjunctival injection. On admission to the ETU, he looked very unwell, and the pulse rate was 128 with an all right blood pressure and oxygen saturation of 98% of room air. And he was oliguric. And what is your diagnosis? Again, just because I'm presenting the meningococcus, it doesn't become meningococcus, it's leptospirosis. However, his blood gas showed severe metabolic acidosis with a bicarb of 12 and lactate of 12.8 and a glucose of 47. And glucose of 47. Does this go against the diagnosis of leptospirosis? And there's this case series in India which showed that 28% of the leptospirosis patients develop hypoglycemia. However, and we diagnosed leptospirosis for this patient at the ETU, and he was given the IV fluid boluses and 50% dextrose because of the hypoglycemia and IV benzyl penicillin. And he was sent to the ward where he clinically deteriorated. He became hypotensive with the persistent tachycardia with persisting hypoglycemia. The blood test came and the white cell count was 7.89 with 90% neutrophils and the platelet count of 79,000 with the hemoglobin of 12.5, and he was transferred to the MICU. He was intubated, ventilated due to the worsening of septic shock and worsening of hypotension and acute kidney injury, and he started bleeding from the puncture sites, and the blood picture came as disseminated intravascular coagulation, and the rotum confirmed that. And a little while later, it was noted that he had this rash, and the dermatologist was called, and he diagnosed the purpura fulminans, and the differential diagnosis was meningococcal sepsis, whether it's a rickettsial infection. And the patient needed escalating vasopressor support, and he was started on CRRT. And despite all this, and with the arrival of a diagonal blood culture result of Neisseria meningitis, he died on day 2 at the MICU with multi-organ failure. This brings us to the problem that we have in Sri Lanka. In the West, if you get a fever and rash, you think meningococcus. In Sri Lanka and South and Southeast Asia, fever and rash is dengue, and sometimes leptospirosis, and rarely overwhelming sepsis. My idea today is to bring the focus into the possibility of meningitis in your patients who present with the same clinical picture. If I bring you to your old days of microbiology, the first clinically characterized syndrome of meningitis was done in 1805 by Gaspard Vissieux in Geneva. Another 85 years later, Anton Weisselbaum discovered the organism, and he called it Diplococcus intracellularis meningitis. And it's a gram-negative Diplococcus, which is anaerobic and facultatively anaerobic. And it is divided into three subgroups by the characteristics of its capsulopolysaccharide. And it exclusively infects humans. The pathobiology depends on the nasopharyngeal carriage and variety of virulent factors. The transmission. The meningococcus rests in the throat and the upper respiratory tract, and it spreads through the respiratory secretions, which requires close contact. Both asymptomatic carriers and the symptomatic patients serve as sources of infection. And the asymptomatic carriage is transient and typically affects about 5 to 10% of the population at any given time. And nasopharyngeal carriage is a prerequisite for the development of systemic infection. Now, you can't just breathe in the Neisseria meningis and develop meningococcal infection. You have to have the nasopharyngeal carriage, colonize, and then later invade. There are factors which determine the infectivity, the virulence of the organism, which is determined by these. I don't want to go through the particulars. And why don't all carriers get meningitis? That is due to genetic variations in the factor H binding protein in human. Factor 8 is a soluble glycoprotein circulating in plasma, and it regulates the alternative complement pathway. The factor 8 helps in sort of stopping the alternative pathway, destroying your own cells. And some of the meningococci, with the aberrations in the factor H in humans, they disguise themselves with the factor H binding protein in their cell wall, are disguising themselves as human cells, and it stops the alternative complement pathway, destroying the pathogen. Epidemiology, it is found worldwide. The highest incidence is seen in the meningitis belt of sub-Saharan Africa. And the large-scale epidemics occur every 5 to 10 years in the meningitis belt. Early outbreaks in the meningitis belt were primarily due to serogroup A, but once the monovalent serogroup A meningococcal conjugate vaccine was introduced in 2010, and the outbreaks are now due to other serogroups. Outside the meningitis belt, infants and adolescents have the highest rate of disease. And interestingly, Hajj pilgrimage to Saudi Arabia is associated with outbreaks of meningococcal disease in returning pilgrims and their contacts. So the people all over the world go to Saudi Arabia, where they have close contacts with each other, and they acquire the meningococcal infection into their throats. They become carriers and get infected, and they come to the native country and they contribute into developing meningitis in the community. And there have been efforts to stop this. We'll go through that later. Now, what are the different types of meningococcal disease in the community? Now, 15% of the meningococcal disease affects the meninges, the central nervous system only, meningitis. And 60% of the people will develop meningitis with accompanying meningococcemia. And 25% of the patients will have meningococcemia without clinical evidence of meningitis. What are the clinical features of meningococcal meningitis? Now, these are the non-specific features. You can have this in any viral fever. Preceding non-suppurative pharyngitis, sudden onset of fever, nausea, vomiting. This will not tell you that I have meningitis. And headache, decreased ability to concentrate. That's an important finding. And myalgias is an important differential sign. The people, especially in the West, during the winter, they get the influenza and they get myalgias. But your patient will tell you, my muscle pain is quite different to other viral fever muscle pains. And they rapidly progress from health to severe disease within hours. And the classical clinical features of meningococcal disease, the hemorrhagic rash, which is common to dengue, common to leptospirosis, common to other overwhelming sepsis. Meningismus is not seen in dengue. And impaired consciousness is not seen in dengue. Until the very late stages in shock, they don't develop impaired consciousness, unless, of course, your patient is a very old person where any fever can make them confused. The signs and symptoms suggestive of early sepsis include severe leg pain, cold hands and feet, and abnormal skin color, pallor or mottling. This brings into my mind a 35-year-old married man whom I saw in 2007. He came to the ward with severe muscle pain from the preceding night with high fever, and his right upper lip was blackish in color, and the limbs were ice cold to touch, and he was very hypotensive, and he had blotchy red rash on the trunk, and he was dead within 2 hours despite all our efforts. On examination, blood pressure was low, he had a rapid pulse rate, postural hypotension, sweaty, petechiae, and Koenig's and Rudzinski signs are not very common in adult patients. The absence of Koenig's sign will not stop you diagnosing meningitis. The petechial rash are discrete lesions, 1 to 2 millimeter in diameter in trunk and lower portions of the body. And if you don't see them, if you suspect meningococcus, look into soft palate, ocular and palpebral conjunctiva, there might be hemorrhages. And over 50% have petechiae upon presentation, and these petechiae coalesce to large purpuric blotches. These are the petechial rashes in different people. This same rash, if I see them, this could be meningococcus, this could be a spotted fever, and very rarely we might see this in the SABE or in vasculitis. The petechial rash correlate with the degree of thrombocytopenia. It is clinically important as an indicator for the potential of bleeding complications second to DIC. A maculopapular eruption, which is different to this, is an early finding in meningococcemia. Shock is a dominant feature on meningococcal meningitis. The patient is poorly responsive, and the peripheral vasoconstriction is maximal with cyanotic, poorly perfused extremities, and your ABGB showed acidosis, and arterial PaO2 will be below 70 millimeters. And Waterhouse-Friderichsen syndrome, the adrenal infarction leading to adrenal insufficiency, contribute to the hypotension. And the DIC will become apparent with extensions of the subcutaneous hemorrhages, gastric or gingival bleeding, and oozing at the sites of venipuncture and intravenous infusions, which we saw in the first case of mango cellar from Blumendal. Purpura fulminans is a severe complication. This is purpura fulminans. It's seen in 15-25% of meningococcemia. It's an acute onset cutaneous hemorrhage and necrosis due to vascular thrombosis and DIC. These patients complain of intense cutaneous pain followed by erythema and petechiae, and ecchymosis develop and evolve into painful, indurated, well-demarcated purple papules with erythematous borders. These areas progress necrosis with formation of Boolean vesicles, and the gangrenous necrosis might extend to deep tissues and even the bones. About the neurological manifestations, if your patient has focal neurological signs and seizures, it is less likely to be meningococcal meningitis is more seen with the pneumococcal meningitis and the Haemophilus. Meningeal irritation is common except in very young and old, and the alteration of level of consciousness is common. It not only affects the brain, it involves the heart, causing myocarditis, heart failure. Myocardial depression is seen in septic shock, but infective endocarditis is very rare. Complications can occur either at the presentation or more commonly later in the recovery phase of the illness due to immune complex disease causing arthritis without the recovery of organism from the joint, pleurisy, vasculitis, pericarditis, epiglottitis, and conus medullaris syndrome and cranial nerve dysfunctions. The management of disease. The diagnosis and treatment is the management, ladies and gentlemen, and diagnosis is made on the history, physical science, and investigations. And we have dealt with the history, and we are going to the physical science. We have finished the physical science, and we are going to the diagnosis. Diagnosis is by the isolation of Neisseria meningitidis from the sterile blood fluids, which are CSF and blood. When you do the lumbar puncture, the macroscopic appearance of the CSF will be murky or purulent. The full report will come as more than 1,000 pus cells with over 180% of polymorphonucleus, and the protein content will be high, more than 80 grams per liter, and the glucose will be less than 4 grams per deciliter, 4 grams per liter. And the gram stain will show gram-negative intracellular diplococci in 80% of untreated cases. If you are given an antibiotic, within 4 hours, usually the CSF is sterile. And then it's the importance of PCR comes. The PCR will be positive even in sterile CSF. These skin lesions, the petechiae, the ecchymotic patches are teeming with Neisseria meningitidis, and you aspirate and send for gram stain and culture. In the management, take cultures and treat with ceftriaxone, manage the circulatory collapse, and do the non-specific investigations. Don't delay the antibiotic for the cultures if they cannot be taken. If your patient is in shock, the management is normal saline, 20 ml per kilogram. In a 50 kilogram man, it will be a 1 liter of normal saline over 5 to 10 minutes. Repeat the same if not responding, repeat the same if not responding. During the third bolus, if the patient doesn't respond, start the patient on vasopressors, start noradrenaline. What is the place for hydrocortisone or the dexamethasone? The hydrocortisone, low-dose hydrocortisone has a place if the patient does not respond to the fluid bolus and then the noradrenaline, and then you give the patient hydrocortisone. Empirical treatment. In non-epidemic setting, that's like Sri Lanka, you treat the patient with the third generation cephalosporin, ceftriaxone, or cefotaxime. Ceftriaxone dose is 2 gram IV BD. On epidemic setting, like in the African meningitis belt, you are treated with intramuscular injection of long-acting chloramphenicol oily suspension by WHO since 1995. The alternatives are benzyl penicillin, ampicillin, chloramphenicol, and ceftriaxone. The older practice was long time back. These patients were given intrathecal benzyl penicillin, which is a killer. Don't give intrathecal benzyl penicillin. The duration of treatment for the meningococcus fully sensitive to antibiotics 7 days, but in practice, it is 14 days of antibiotics in the hospitals, which we can't sort of change at the moment. Adjuvant therapy, dexamethasone has not shown to be beneficial in the meningococcal meningitis, though it is beneficial in pneumococcal and Haemophilus meningitis. It should be discontinued once the diagnosis is established. Protein C concentrate, which was suggested in the past, the limited data suggests that protein C concentrate might be beneficial in patients with meningococcal sepsis and purpura fulminans, but the newest British guidelines don't recommend protein C concentrate. How to prevent and control droplet precautions? We are doing it at the moment with the COVID and vaccinations, chemoprophylaxis, and avoid risk factors. There are a lot of vaccines available. What happens is when you give one vaccine, the other sero group causes the infection, which happened in the African meningitis belt. So we have the quadrivalent meningococcal polysaccharide conjugate vaccines, which are used. The chemoprophylaxis, where you give the drugs to stop the transmission. It's an important source control measure. Who are given the chemoprophylaxis? The first people are the close contact of cases. If the person is from a school, a child, from a nursery, is from the jail, or if from a military institution, you give the chemoprophylaxis to everybody who was the children in his class. Contacts with oral fluids of patients, those who kissed him, who shared a glass of water with him and beverages. And the patients with meningococcal infection who were treated with antibiotics like penicillin and the chloramphenicol, which does not eliminate the carrier state. And if started early, preferably within the 24 hours from initial contact, it will stop their carrier state and stop the nasopharyngeal carriage of the Neisseria meningitidis, which is a prerequisite for the infection. The chemoprophylaxis drugs are ciprofloxacin, ceftriaxone, and the rifampicin. In good old days, it was rifampicin 600 mg BD for 2 days. At the moment, ciprofloxacin 500 mg orally as a single dose is recommended. And travelers to high-risk areas. Travelers to areas affected meningococcal outbreaks are advised to be vaccinated. And Saudi Arabia requires visitors to obtain a tetravalent vaccine at least 10 days prior to their arrival in the country when they come for Hajj and Umrah. So that is to stop the Hajj pilgrimage, bringing the meningococcus back to their native countries. Notify the epidemiology unit of the Ministry of Health whenever you get a meningitis, the meningococcal patient. And my thanks to Dr. Minuri Fernand, who's the registrar in medicine at National Hospital, and Dr. Dilshan Priyankara, who's a consultant intensivist at the National Hospital of Sri Lanka.
Thank you, Dr. Dissanayake, for that wonderful presentation. There is one question. With your experience, have you seen patients who have survived meningococcal sepsis? And what are the statistics that we have at the moment in our country?
To see whether we have got recent statistics. Unfortunately, the recent statistics are not available because of the prevailing situation of the country. If I look at the local data at the National Hospital from March last year, we have diagnosed 6 patients with meningococcal sepsis. And 1 patient had the meningococcal septicemia, who died the mango cellar. Other 5 patients had meningococcal meningitis confirmed, and all of them survived. So it's probably our practice of giving antibiotics early when we see sepsis. It need not be, you need not diagnose meningococcal septicemia. You see a patient with sepsis, you treat them with fluids and the antibiotics, appropriate antibiotics. Fortunately, our antibiotic of choice at the moment for empirical treatment is ceftriaxone. So probably it saved them.
Also, you mentioned that, of course, we mentioned that common things are common in medicine wherever you go. However, scrub typhus also can present in similar ways. Is there any different way that you can differentiate clinically without any investigations meningococcal infections?
It's a difficult question. The reason is that my experience with scrub typhus is only about 2 to 3 people. Whereas when we went to Navalapitiya, the physicians at Navalapitiya were seeing about 10 to 20 a week. So probably those patients with scrub typhus are not very sick, and they don't deteriorate within 1 day. What you see in meningococcal meningitis, the person is was all right a couple of hours back, and the disease progression, they were all right, and they complain of severe body aches, pains, myalgia, confusion, and they develop this rash, which is seen in the trunk and the legs. In the scrub typhus, probably the patient doesn't have that clinical scenario where the person becomes sick over the hours. Probably if your patient has scrub typhus, but if your patient became sick over the hours, there's no harm treating him with meningococcal meningitis, meningococcal sepsis, and then think of scrub typhus.
Thank you, Dr. Dissanayake, for that talk.